special concerns about winter health? Tonight, On Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. Oh, the weather outside is frightful. What are the special concerns for those of us who live where winter visits with an enthusiastic vigor? We are On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. With below zero temperatures keeping us stuck inside, seasonal affective disorder and the cold and flu season are reaching their peak. And we're having rapidly changing weather that can affect driving conditions or even our safety walking down the sidewalk. With all this, it is even more important to take steps to stay active, safe, healthy. Tonight we discuss everything dealing with winter health, and feel free to call and ask questions about anything. This is an Ask Anything of our panel. Stump these people. See if you can get them a question they don't know. We have a good group who has a wide breadth of knowledge to answer your questions. I am joined tonight by surgeon Dr. Mary Milroy, a general surgeon at the Avera Sacred Heart Hospital, Yankton, South Dakota, and internist Dan Meagard, an internist from the Yankton Medical Clinic. Thank you both for joining us and coming up from Yankton.
Actually, we're both partners at the Yankton Medical Clinic.
Yes,
so,
there you go,
So
partners.
we've actually worked together for more than 20 years.
23 years.
23 years.
So we have an internist and we have a surgeon.
Yep.
I can challenge you. There isn't anything you can ask them that they don't know something about, almost.
Maybe.
Maybe.
We hope so. We do hope so.
So, Mary, tell us a little bit about yourself. Where are you from originally?
Well, I actually was born in Winnipeg, Manitoba, but my folks moved down to the States when I was about 3 years old.
So you can't be the president of the United States?
No.
You're Canadian.
Like I would want to, right? No, that's not my goal. But it's not on my bucket list. But anyway, I grew up mostly in Minnesota, went to University of Minnesota as an undergraduate, but did attend medical school in South Dakota. So I had a chance to move to Vermilion and
You spent some time in Brookings?
I did. I think my first family medicine rotation was in Brookings.
With whom? Walt Pat, did you say?
And I'm going to say, I'm not sure exactly. I think they rotated us around quite a bit, but it was good.
So, and then you did your fellowship and residency in surgery.
Okay, and actually I married a classmate, fell in love with South Dakota, and so it's been great. I'm now a transplanted to South Dakota person.
So you are truly a South Dakotan.
I'm truly a South Dakotan. And then I did a year of internship out at Highland, Alameda County in Oakland. So I did a first year surgery out there, and then spent 3 years with the U.S. Public Health Service, and I was at the Indian Health Service Hospital up in Sisseton. So I actually did real medicine, non-surgical real medicine for about 3 years, and I decided that I truly did like surgery. So I went to Michigan State and completed a surgical residency. Stayed and taught there for 2 years on the faculty, and then really wanted to move back to South Dakota. I was done training, wanted to move home, And actually, Yankton was about the first place we looked, and I
a nice place.
must have fit because I've still been there 23 years later. So,
And
it's been good.
And you evolved as a general surgeon into breast
Right.
surgery. Tell us a little bit about that.
Yes, I found that as I was practicing, many women did want to see me. I think when I moved to the state, I was only the second woman general surgeon in the state. Women really wanted to see me when they were having issues with their breasts or their mammograms. And at the time, I also had a small family, and so it was more of a clinic practice than regular general surgery. It didn't have so much trauma and things.
Yeah.
So I found that it was a wonderful fit. It was something I enjoyed doing. It seemed it was something that women appreciated, and it fit very well with the family.
I mean,
So-
earlier we talked about stereotactic surgery and all those localizations of lesions and so on and so
Yeah.
forth. It just amazes me that what we can do now with breast cancer.
Amazing. You know, I often tell some of the pre-med students and the medical students, you know, so much of what I trained has completely changed. You know, when I started, and I'll have to tell you a story. This is, when I started, one of my first times in residency, we were still doing, if a woman came in with a lump, mammograms weren't done as much then, a woman would come in, she would sign a consent that was for a biopsy, frozen section, possible mastectomy.
Yeah.
So sometimes we would give women a general anesthetic, they would go to sleep, they would wake up not knowing if they had cancer, had they had a mastectomy, what happened? And women would be tearful in the recovery room,
Yeah.
what happened to me?
Yeah.
You know, nowadays we want our patients to be active participants in their care and their decisions.
Yeah.
And I look at that and I think, oh, wow,
There's a change.
that's not the way we do it now. I said, when I look now, the majority, well, the good news is that the breast cancer mortality rate has gone down almost every year now for 2 decades. And that's due to a couple different things. One is early diagnosis. I mean, I think people are more aware, they have mammograms. It also opens avenues to have lumpectomies. The majority of my breast cancer patients don't spend one night in the hospital. They have their lumpectomy and go home.
And the radiation, they don't lose their breast.
They don't
anymore.
lose their breast. They can have radiation, they save their breast. They have a better outcome. It's great. Also, some of the advances in diagnosis, we do so much of it by image guided, where you can have a small office procedure versus going to surgery for a biopsy. And then some of the major advances in some of our medical oncology, between kind of the early diagnosis and that, it has made a dramatic change. So things are better. We're not perfect yet, and the goal is no deaths, but it's marching the right way.
Right. It's an Ask Anything show, so call us at 1-888-376-6225 or email your questions to ask@oncalltv.org. So Dan, you're from where originally?
The big city of Sherman, South Dakota.
Sherman.
You're familiar with Sherman?
No, I'm not.
No.
I don't remember where Sherman. I've heard that.
Sherman is about 3 miles north of Garrettson.
The bigger city.
The big city of Garrettson. But I went to the metropolis of Del Rapids, the high school. And from there, I went to.
Are you a farm kid?
I'm a farm kid. Grew up on the farm, and actually, we showed cattle and hogs all over the upper Midwest. So I very much was about that far from becoming a farmer. The only son of a farm family. And then went from.
And you disappointed them.
In many ways. This is probably one of the few, maybe the only profession I could go into. Maybe veterinary medicine would be the only one that would be considered an option that would be acceptable. But then I came up to campus here at SDSU. And
Go Jacks.
I was a rabbit for 4 years. And then went to USD to medical school. And then 3 years at the University of Missouri for residency.
Oh, yeah.
And then after residency, I worked as a hospitalist, or at that time would be called an intensivist.
Yeah.
I worked in an ICUs in St. Louis for 6 months.
Oh, wow. I bet that was a great job.
That was very interesting and very intense. We did bypass surgery, so I would take care of post-bypass patients, immediately after their surgery, and all kinds of other things in an intensive care unit. Very intense, very fun, but I knew that was a temporary job because I'd already signed to come back to Yankton and the Yankton Medical Clinic, and so I did that for 6 months because I was waiting to get married in Missouri.
Oh. And then you dragged that poor woman back to South Dakota.
Drug her back here to the beautiful weather and the nice people.
Yeah, I did that same thing to a Floridian, the poor lady.
That's even
Scratches, scratch marks all the way from Florida.
I'm sure. I think I passed him on I-29 actually on the way up.
So, do you do any hospital work now, or are you mostly outpatient?
We have what I would call an infancy hospital program in Yankton. We have a 12-hour hospitalist program, which just doesn't have enough physicians in it yet to take care of all of our patients. So I still do both inpatient and outpatient medicine. My trend is probably leaning more towards outpatient, every year that I practice.
Yeah.
But still, I still have a significant component of patients in the hospital, including this week. There's more than enough
You're
there.
busy this week.
Yes.
I am too. I do both, just like you do. And I think moving toward the hospitalist system, I think we lose something, I'm afraid. But that's a bias, and it's nice to have somebody available and to be able to get some sleep too.
Right.
We talk about the flu, arthritis, psoriasis, etc., but often a disease can show itself in different ways. Pneumonia can arrive in a variety of forms, and it's important that we know the variety with which we are dealing in order to provide you effective treatment.
Well, I've been in practice for almost 29 years after residency, so I had a number of interesting cases here and there. One that's most recent that I remember, it was actually a family member of one of our office staff, and he works as a welder and a machinist, so he's pretty heavy-duty guy, and he'd been ill for a week, and of course didn't come in until he was all but passing out and had fever and chills and was extremely weak and dehydrated and was really ill, and had respiratory symptoms, and he was starting to get jaundiced, and he was very ill. So we put him in the hospital. He had a pneumonia, which was somewhat atypical. It had different areas of involvement, not just one local area. And so we put him on our, we usually start with a shotgun approach, or you put on multiple antibiotics to cover pretty much everything until you figure out what it is. You do cultures in the meantime to figure out what it is, try and culture sputum, culture blood, culture whatever you can to find out what the organism is, and we did that, but that takes a couple days or a day or two. And we also involved infectious disease specialists, which we do now via telemedicine. We use an interactive video setup, and they can interview the patient, and of course some of it is secondhand, they get information, but they assisted and ordered some other tests too. And anyway, what it turned out to be was a case of Legionella, or Legionnaire's disease, which we don't see very often at all, and certainly don't in our part of the country. It had, it was originally described at a Legionnaire's convention, or Legion convention, where they had contaminated airflow, ductwork, and got it through that type of infection. But we couldn't pin down how this individual got it, but very interesting. But our initial antibiotics got him started getting better, and then we got more focused when we found out what it was, and he recovered uneventfully. So it was a good case.
That was Kevin Bjordahl. He's from DeSmet,
I
Good
know
guy.
him.
Yeah.
He's a good
So
guy.
I've heard good things about DeSmet. So, interesting, I've had a case or two or three of Legionnaires in my experience, always waterborne, sometimes air conditioners and so on and so forth. And what would you had a case?
I've seen two cases I can think of off the top of my head. One would have been in the 80s, not too long after Legionnaires had been described.
Right.
And it was a young kid from a military base who actually ended up dying from it. And we knew what it was. I'm not sure we knew exactly how to treat it. And he died from Legionnaire's pneumonia. I had another case here just a few years ago that we covered them for Legionnaires right away, and they did very well.
And they do okay. It's interesting. We have a lot of respiratory infection. I have a cold right now, and I feel fine. I have a little bit of a cough, And the clue that it's virus is it hits the voice.
Yeah. Yep.
The voice is gone, you know, then the antibiotic doesn't make
Doesn't
a difference.
do a thing. Yeah.
Some people say, well, if it's a virus and I'm really sick from this, why don't you just give me an antibiotic in case? And I've read experts that said that it doesn't prevent the viral respiratory infection from going on to becoming bacterial. It only makes it a resistant organism. What do you think about that, you guys?
I agree with that. I mean, I don't think you should prophylactically treat like that at all, because most viral infections get better on their own.
Yeah.
You know, so
And when they turn bad, then you start having shaking chills 3 days later, you call your doctor.
then you know what it
Right.
is.
I think a lot of people come in and say, 20 years ago, my doctor used to give me a shot of penicillin in the
Yeah.
backside, and I was better in 2 days.
Yeah.
Well, they probably weren't getting better because the virus went away, and the penicillin did nothing for them. And we need to educate patients that's not the way it works anymore, and we're not going to do that because it's not good medicine.
Well, and it hurts
Yeah, they
them.
probably would have got better in 2 days without the shot.
course they
would've.
So
Of course
they would've.
they spared themselves the pain.
Yeah.
Well, and the problem is that now we're having these terrible overgrowth problems related to the antibiotics.
Yeah, antibiotic resistance is becoming a real issue. So I think all of us need to be very careful with how we use our antibiotics. And I think part of that's educating our patients so that they realize that probably is not the best way to practice medicine.
No, pneumonia is a-
And
Yep.
and maybe they didn't know better in those days because they didn't have antibiotic resistance, but now we shouldn't do that.
We really have resistance. I had a friend who got a bad cold, and he didn't let me know. He didn't tell anybody he was sick, right? After about 4 days, he started having chills, and he still didn't let anybody know.
no.
And his pneumonia just about took him out.
Yeah.
So it was bacterial pneumonia. He's alive. Saw him last night. Looks great.
Good.
And thank goodness that we do have antibiotics that work yet.
Yeah.
Absolutely.
Any other take-home messages on that? We're going to dive into some questions.
Well, one thing I would say is I think people need to be careful because so many viruses are around, and it isn't fancy antibiotics that really make a difference in our health. I think it's simple things. It's things like washing your hands. It's things like staying home when you're sick,
Cover your cough.
so that you don't spread it to everybody at the office or the school.
Yeah.
Cover your cough. You know, it's those kind of really pretty simple, easy things make a huge difference.
Yep, they do.
Good common sense.
And get the flu shot.
And get your flu shot for sure. Absolutely.
Saves lives.
Oh,
There are people
yes.
dying from flu.
Oh, I think just driving here tonight, I heard on public radio I was listening to, they've had several young people die of the flu. So get the flu shot.
Yeah, even this year when it's the word is it's not as effective and the virus has changed a little bit, the shot's not as effective this year, still get it. It's 50% effective. I had influenza 6 years ago. I thought I was going to die. It's awful, and if you get pneumonia on top of influenza, it can be a killer.
Yeah.
Yeah, even
can.
at young, healthy people, it's
It
well
can
worth
kill.
getting. Oh,
And
definitely.
look at Jim Henson. I mean, he died from
Yes,
pneumonia,
right,
but
from pneumonia.
I'm certain they say 90% of all the pneumonias start with a viral respiratory infection, and then they don't come in after 3 or 4 or 5 days when they start getting sick again.
Get real sick.
From Volga.
Okay.
Can good cholesterol be too high? Talking about HDL, Dan.
Okay.
Absolutely not. The higher the better. Good cholesterol or HDL is protective. I saw somebody earlier this week, a lady who had an HDL, I believe, of 98. Her total cholesterol was about 230. So her ratio between total and good was outstanding. The higher the better with good cholesterol. Anything above 40 is kind of the goal. Above 60 is outstanding, and if you're up at 90 or 100, more power to you.
But why is it? Do you have any idea what the theory is?
Most of the time, I think when people have really high good cholesterols, it's genetic. You're blessed with the right genes that you're going to have high good cholesterol. Women, luckily, have better genetics and have
Exercisers.
exercisers have good HDL,
yeah.
but still, you get those people that are up 80, 90, or 100. They are born with a genetic predisposition to have wonderful cholesterol, and you can't ruin that.
Okay. From Aurora, tell me about fibroid tumors. What causes them? How to treat or live with them, or what not to do? Fibroid tumors. What are they?
Well, I would say there's-
Fireballs of the uterus
Yeah.
is what they
I
used to
was
say
saying, yeah.
in Atlanta, Georgia. Fireballs of the
Fireballs.
uterus.
I think that what happens is they're pretty common. They're often in the uterus, And I don't think anybody really knows why they form. For a number of women, they really are not a problem. They're fairly common, but some people do end up with heavy bleeding, and then it is important to go ahead and see your gynecologist, because sometimes treatment does need to be necessary.
And you can get large uteruses from fibroids.
Oh, very large.
Fibroids.
You bet.
And
Sometimes
so-
they can grow really to amazing sizes.
Yeah, and benign though. They're benign
Right,
tumors.
they're benign. They're benign. I think sometimes I get people that come in and they have a fibroadenoma in their breast, and they get very confused. They're actually different entities, but they are another kind of fibrous. We don't know why they form.
And benign.
Usually benign, and usually no problem, and sometimes you can just let them be. So.
Okay. From Yankton.
Okay.
Your home.
All right.
A 76-year-old man said pneumonia shot sent it had several years ago to be once. Now there is a booster. Oh, a pneumonia shot.
Pneumonia shot.
So tell us about pneumonia shots, Dan. And there is new word about Prevnar, which is the other pneumonia shot.
Right.
Pneumovax and Prevnar, and shingles shot. So hit us on all three
Well,
of those.
let's start with the two pneumonia shots. The Pneumovax, or a 23-valent pneumonia shot, has been around a long time. Oh, I don't know. It's been longer than I've been in practice. I'd say 30 or more years, Rick.
I remember when it came in. So
Yeah.
about 30 years.
30 years, and it's the recommendations regarding that shot. I've been in Yankton 23 years. The recommendations changed 3 times in the first 5 years I was in Yankton, and since then, the last 18 years, it's basically stayed the same. A second shot, which is a 13-valent pneumonia shot, has come
So
out.
it covers 13 different pneumonia.
13 strains of pneumococcal pneumonia, which is the most common type of pneumonia, versus the old shot was 23 strains.
Right.
This newer shot's been around a number of years now too, maybe, I don't know, 10 or something like that. And they both have their advantages. The 23-valent covers 23 strains of the most common type of pneumonia. The 13-valent covers 13 strains. You might say, well, 23's got to be better than 13, at least in Del Rapids math it is. And then, but apparently the immune response to the 13 is better for those 13 than it is for the 23. So they each have their own advantage. The CDC, the Center for Disease Control, just came out and said, we think, there's now enough evidence that you should probably have both. And so the recommendations are, if you've had the 23-valent, get the 13-valent also, but get it at least a year apart between the two. I think there's still some concerns about who's going to pay for this, and so I've been telling my patients right now, let's wait and not, let's make sure Medicare is going to pay for it before we give the second one.
What I've heard is the Prevnar, the 13, is the one that they've been traditionally giving to the kiddies, and that's the one that has probably made the greatest difference, because it's the illness in the kids that spreads to the adults, and if you can prevent the illness in the kids, you save adults their illness. And the adults, the older adults who get this, their immune system is not as strong as the kiddies too. So I think you're right, particularly if you've got an illness like asthma or diabetes. Then you get the two.
Yeah, and if you have one of those diseases, asthma, diabetes, kidney failure, liver disease, even chronic heart disease, a type of cancer, you should probably get the pneumonia vaccine, one or the other every 5 years.
Okay. And one quick word about Zovarex.
Zostavax?
Zostavax.
Zostavax is the
Yeah.
shingles vaccine, and it has been shown to reduce the chance of shingles by 62% in the next decade after you get it. It's a one-time shot. It's recommended at age 60. Most Medicare D plans will cover about 75 to 80% of the cost of the shot. If you can get this shot for, it's an expensive shot, it's $350 or so, but most Part D plans, you get it for $75. If you get it for under $100, it's a great deal. Get it. The manufacturer would like you to get it starting at age 50. Insurance says 60, so get it at 60.
Yeah, get it at 60. It reduces the post-herpetic neuralgia pain by 50% as well. Ask me if I've had it.
Have you had it by chance?
I have.
And how was it?
Well, I've not had any shingles, so I'm glad. It was wonderful.
Are miserable.
Terrible.
I had my shot too, so
There we
I don't want to. I've seen enough patients with shingles that I don't want it.
Don't want to go there.
I don't want to go
no.
there.
The effective treatment for some diseases isn't a pill or surgery. The proper course may be as simple as a pair of socks.
I had a sore on my ankle, right at the ankle bone. They called it an ulcer. Anyway, it got to be just like a hole the size of my fingernail, and it just wouldn't heal. Well, finally, Dr. Holm, after probably a couple of years, said, let's try support hose. So we started with support hose. It took a while, probably 2-3 months, but all of a sudden it started healing up. And I haven't had any trouble since, but once in a while I feel like it's a little bit tender there yet. Then I got varicose veins. That's another reason that I wear these. And it's so comforting. Before I had the restaurant, I was on my feet probably 16 hours a day. And my calf would get so sore and tender and ache. So I started wearing them, and that didn't cure the varicose veins, but it sure helped the pain. Yeah. So, and the left foot, the left leg, that's not any problems. So it's the right leg that I've got wear this support hose for. Take your left hand down and your right hand to the side and bring that as far as you can up to towards your toes. Then you take your thumb, get your 3 fingers down, bring it over the heel, and your sock is resting on the floor.
Thank you, Mr. Erickson. I can't tell you how many people I have who have trouble putting those darn things on and taking them off. They won't do it, and it is such a benefit. I mean, you know, those ulcers went away once you started treating them with support hose. I've had wonderful results. I had one lady mad at me because I didn't start them soon enough. Once they got used to them, that's the issue. Dan, what's your experience on support hose?
I think it's great, especially for the people that have venous stasis, venous insufficiency, varicose veins. It works really well in those situations.
Right. Mary?
Oh, I would agree. Some of these chronic ulcers take forever to heal. So if you can prevent them and heal them and not get them back, it is wonderful.
And the hose is the key. Brookings, how effective is Tamiflu or other antivirals for treating viral infection? In particular, does it reduce the time of illness? Dan?
Well, I might try that one. I think it varies from year to year. Tamiflu is typically fairly good for influenza A. It's not as good for influenza B. And that's probably true of all antiviral agents for influenza in general. So it's not the easiest disease to treat. There's also talk of shortcomings in the supply this year, and so probably if you're young and healthy and you get influenza, you probably won't be treated by your doctor. No. If you're older and not healthy, you probably will.
I'll use Tamiflu if they're sick enough to be in the hospital. I'm not giving it out otherwise.
Yep, I think that's a good policy.
Okay.
That makes sense.
Sioux Falls, cause of interstitial cystitis, some treatments, discuss treatment. Mary? Interstitial cystitis, bladder.
Yeah, honestly, I don't do a lot with the bladder other than, if I have a patient that's having much trouble with that, I usually have them see a good urologist because it can be a miserable problem, but it's not one that I really do much with.
Okay.
Dan? Do you do much with that? Or?
I've had a few cases. Typically what works best is intra-bladder infusions of some medicines you can actually give in the bladder that work fairly well. One I think is called Almiron, but I once again, I don't have a lot of experience with it, but
people can be really miserable.
They get really miserable with that.
I've had one patient who was so miserable they just took out her bladder and made a bladder from a pocket from her colon.
Sure.
And or small intestine, I think is what it was. That made a lot of difference. Here's mixed martial arts promoted by Sanford Health. Is this okay? What do you think of mixed martial arts?
Certainly not an expert on that by any means. I think that any type of physical activity like that, there's always a chance to get hurt. It's no different than football without pads, I think.
Yeah, well, Barry?
And I'd say if you find an activity, a physical activity that you enjoy, go for it.
Yeah.
It's great. Get up, get moving. It's good.
I've heard a lot said about Tai Chi as a perfect thing for an elderly
Yes.
person, for example. But the most important thing, I think, is that you stay active, that you're going, that you get out of the igloo, that you unless you're sick.
Get
Well,
off
you find-
the
yeah.
couch.
Get off
the
that
couch.
darn couch. Okay, and do mixed martial arts, not traumatic martial arts, but
It's just, you just got to find an activity that you like, and then it's not a chore. It's something you miss if you don't do it, and you want to go do it. So
in China, we were there picking up our daughter, and then we
Yes,
went back
yeah.
again. And in the mornings, if you go out and you go for a run early, they're out in the park doing these, the kung fu posturing.
well, the Tai Chi. They're doing the Tai Chi,
And
which is
then there are
wonderful.
people doing sword things, and there are people. I mean, it's just amazing. But they're out.
But they're out.
They're doing their
we
stretching.
had a very similar experience. My daughter was teaching in South Korea, and so we had the chance to go out in the morning, and we couldn't believe how many people were up, really elderly people. And they were all
Doing
out,
some-
and they were doing a
their
lot of
stretch.
those stretches and balance. A lot of elderly people have a great trouble with balance. Balance, range of motion,
And you come
and
by-
you're getting up, and you have a social contact.
Yeah.
You're out doing this together. You're out in the fresh air.
You would come by a
That's-
company and all of their workers were all dressed
They're all
the
out
same.
there.
They were all out there doing their morning pre-work day exercise.
Which is fabulous. We should all make it a part of our day. It's great.
They're ahead of us on that one.
Yeah, that's one we should copy.
Hills, Minnesota. Caller had a car accident, L1 vertebrae compression 20%. Is this likely to get better? What should she expect? Dan.
Well, it's a pretty common injury. Compression fractures of the spine are a common injury. We see it a lot. I think there's two different approaches there. One is that you can just wait it out, which has kind of been the way we've always done this. And most of the time, in about 6 weeks, the pain is going to be gone. And just like a broken bone, this is a broken bone, no different than breaking your wrist or your ankle or something else.
But it's stable as a rule.
It's stable.
It just hurts.
It just hurts, and usually in about 6 weeks it will heal. At 20% compression, they might manage that conservatively. If it was compressed more, 50 or 80%, now they can go in and they can actually put some cement in there, re-expand that vertebrae, and decrease your pain quicker. And
But
that
to the tune of $30,000 in a risk. That's the only other thing.
yeah, and at 20%, they're probably not going to want to do that. I would manage that conservatively.
And try to stay moving. I think the most important thing is they go, oh, I've collapsed a vertebra, I can't move, it hurts,
Yep.
and they don't move, and then they have pain forever.
Yeah.
If you get moving, it's like pelvic fracture. You got to get them moving.
Get
Yep.
moving.
Huron, South Dakota, talks in his sleep. What is this called, and how common is talking in the sleep, and what does it mean? Barry, you know anything about talking?
I know nothing about
Dan,
talking
you
in
know
your
everything.
sleep, I guess, here.
I don't know much about talking in the sleep. I do think, though, that it's probably a pretty safe bet that it's not pathologic and doesn't require any intervention.
Unless he's saying nasty things.
Yes.
Well, it depends about he's talking about other women or
Yeah.
something. He'll be in a lot of trouble. Depends on what he's saying, right?
Yeah, there's a lot of sleep things that are weird. I mean, there's
Yeah, there's some
sometimes
unusual
where they
things.
start hitting their partner because they're having a
Yes.
dream that they're being attacked. And it's dangerous for
Oh,
their
yes,
partner.
right.
But
That's
talking in the sleep, I think it all depends upon what you're saying, because then your partner might be hitting you if you're
Yeah,
saying
you got to
it.
be careful what you say, I think.
I don't think it means anything except that we have a part of our brain that turns everything off when we fall asleep so that we don't sleepwalk. And there's things that can be happening that turn off doesn't completely
Doesn't
happen.
completely.
And so I think getting correct sleep, certainly sleep apnea needs to be looked into. Drugs can cause this kind of thing. Be careful. Have a checkup. Any other thoughts? Watertown, do those of us living in this area really need vitamin D this time of the year? What's your take on that, Dan?
Absolutely.
Yes.
I went to a conference a few years ago, and there was a vitamin D expert there from Boston, and he gave an hour lecture in vitamin D, probably the best lecture I've ever heard. And he said if you live north of Atlanta, Georgia, which I think Watertown is north of Atlanta, Georgia,
just a bit.
by a couple miles, but if you live north of Atlanta, Georgia, by April 30th, 83% of us are vitamin D deficient. So I take one supplement myself, vitamin D. I take it seasonally from 1st of November till the end of April. And I take about 2,000 units a day.
Yeah.
You might say, well, now the FDA says to take 400.
Yeah.
You know, well, there's a request that's gone into the FDA to increase it to 1,000. I think pretty much everybody agrees that the FDA is way too low for vitamin D. I tell my patients, if you're going to take vitamin D, if you're going to take it year-round, take 1,000 units year-round. Take 2,000 if you take it seasonally.
Yeah. Ask me if I take vitamin D.
No.
I do.
Do you?
No, I didn't ask you.
Well, you could ask me.
I do take
All
it
right.
myself.
All right.
So 3 for 3. We take vitamin D.
I think we all do.
All right. You take it too.
I do. I absolutely
3
do.
for 3. Vitamin D, 2,000. I take it year-round. It's hard not to get carried away when we fill our plates at Thanksgiving or Christmas dinners. We all know that the extra food can cause problems with which we will have to deal for several months. But with a bit of self-control, we can take our cake, have our cake and eat it too. Or maybe during this time of the year, it's the pie that we can have.
Mashed potatoes, sweet potato casserole, Grandma's green bean casserole, and Mom's apple pie. Do these foods sound like a part of your recent holiday gatherings? Most of these foods can be considered comfort foods or even traditional holiday foods. Comfort foods can certainly be a part of our diets in the winter. It's the how much and the how often that we need to pay attention to closely. Whether you are planning a menu for your family's holiday or just a weekly menu at home, focus on the balance or the how much. Use the plate method that is beautifully demonstrated by the Choose My Plate message. Focus on half of your plate being fruits or vegetables. Limit your protein to 3 to 5 ounces per meal. Add a serving of grain or a starch, and don't forget a cup of milk. Next, remember the how often. With numerous holiday gatherings each week or cravings for comfort foods each day, it can be very easy to include too many comfort foods too often. Take a step back, look at the events of the week and your menu plan for the week. Allow yourself some of these foods and some of these events, but try not to allow them more than just a few times per week. It is common for those who live in the cold winter states to gain weight and lose strength during the winter months. Having balance and limiting excessive calorie-dense foods can help us to feel better during this time. And finally, getting plenty of exercise will help us maintain strength, prevent weight gain, and still be able to enjoy limited amounts of those foods that keep us comfortable during this time of year.
Thank you, our dietitian, Katie Vanderwall. What a plus she is, and the balance is the most important thing. And that's interesting. We only gained 1 pound, not 5 pounds, they said. Of course, a lot of people talk about loginess. And I guess my answer to them is eat those festive days, but make sure you also exercise. What's your take home on all that food this time of year, you guys?
You know, I think an idea is moderation. You don't need 4 helpings of something, or, just take the foods that you like and enjoy it. I mean, it's part of the holidays, but maybe just portion control and keep moving.
Yeah,
So.
Dan?
I agree. I have been one that's probably eaten as much as I've wanted I'm now 52, for 50 years. I think I could eat anything and eat as much as I wanted. Now I realize I can't do that anymore. And so I'm learning moderation for the first time in my life.
I've always had to have moderation since college. I really grew. And the clue that I've done lately that has helped me is I've filled the plate with smaller amounts, and with the idea that I can come back. And then take your time, and then you go, I'm full. Why would I want to go back? So you don't just dump it on high and then eat it all and then go, ugh.
One other challenge we're doing right now at our clinic is called the Healthy Hydration Challenge. Yeah. And the challenge is just to drink more water in the course of a day. And I've actually really tried to incorporate that into my day, and I have noticed that I'm not as hungry. I drink more water, I trick my stomach into thinking it's full, and it is, of something that has 0 calories.
Yeah.
And sometimes I think we're thirsty and we think we're hungry, and then we try and fill it with the wrong thing.
Right.
And I think some of us were raised with our moms all saying, clean your plate.
Yeah.
And I think now, it's much better to slow down and maybe just savor and enjoy your food. It takes your brain a little while. It's a little slower than your stomach, I think.
It is. I think you're
and
right.
so take your time, drink your water, savor your food, and you probably end up eating less. And it's okay to leave some on your plate when you're full.
That's right. So quick answers. We got a
Oh, I
bunch of
know.
questions here
Gosh,
from
okay.
Freeman. If you are diagnosed with pneumonia, does the provider usually check to see if Legionnaire's or amyloidosis?
Well, Legionnaires, yes. At our hospital, we have a
Atypical pneumonia check.
yeah, we have a you can check for atypical pneumonias, and it's just a little box that we check when we're doing admissions, and so we do check for that. Amyloidosis is very rare, and we would not check for that unless we were, we couldn't find anything else.
Right. There's clues that generally pop up. Chest pain while shoveling during the winter season with shoveling snow. Do we have any clues about shoveling snow? People go after shoveling too hard, don't you think? I mean, what's the story about shoveling snow, Dan?
Well, certainly it's a big risk factor for myocardial infarction or for angina or myocardial ischemia. And so for people that are little couch potato-ish and not very physically active, if you go out and start shoveling 8 inches of snow, you're kind of you're doing a stress test like you would at the doctor's office, except the doctor's not there. So
That's right.
You got to be careful when you're shoveling snow, especially if you're not used to doing any type of that kind of physical activity.
Right. If you're not in shape, don't do it.
Exactly.
Mary, any other take-homes?
And I would say too, if you start having some chest pain, don't just be a macho person and keep staying out there.
Get to the
It's time to make a call and go to the ER.
Exertional
that's
chest
serious.
pain.
Yeah, that's
right.
serious.
That's it. Anything about carbon monoxide poisoning this time of the year? I had a patient this week whose dad died of carbon monoxide, and what had happened is a bird had filled the chimney, and the mother got sick because of the carbon monoxide. She went to the hospital, the kids went to the neighbors, and he died.
Wow. Oh my.
And so that's a real deal.
That is
We
a
should,
real deal.
You should really check your chimneys and the vents as well of the sewer vents when the snows and it gets
Have a
high.
carbon monoxide monitor.
Make sure you have one of
Really
those.
a good
Absolutely.
idea.
They're not
Absolutely.
expensive.
Right.
They're-
What symptoms does a person have with carbon monoxide poisoning?
I think most of the time that people just become sluggish and don't act like themselves, and
Confusion.
confusion.
Headaches,
People
I think.
people will come in and say, you're not right. What's wrong with you? And that can be a clue. But it's very subtle. It's very hard for the individual themselves to identify it before it's too late.
It might be interesting, if you do a blood test for carbon monoxide, it's a nice sensitive test for it unless you're a smoker. If you're a smoker,
then-
you got high levels of carbon monoxide in there, which is one little scary comment about smoking. Here's a Brookings 71-year-old aunt with pulmonary fibrosis. Normal age of onset. Please discuss pulmonary fibrosis. Mary, are you a pulmonary fibrosis person? Do you understand that one? Dan does. What it is?
Well, pulmonary fibrosis is it's a fairly common disease. It's basically hardening of your lungs. It's where your lungs become very
Scarred.
dense and scarred, and they don't expand. And it could occur for many reasons. People who've had multiple cases of pneumonia, for instance, could get pulmonary fibrosis. People can get it because of something they've inhaled through their career in their job, or it can be idiopathic, which means we don't know. And it's a not uncommon. It's a tough problem to fix because we don't have any good medicines to make it better quickly.
No, and it's different than the asthma because they can get the air out. Asthma, you can't blow the air all the way out. It takes a long, long, long time. They blow out fine, but it's just small volumes.
Yeah.
And you can diagnose it because it crackles like
You
cellophane.
can hear it with the stethoscope
Yeah.
very easily.
Yep. Worthington, Minnesota caller read an article saying that eating processed meats like bacon can cause pancreatic cancer. Any truth to that?
I don't know that I've seen an article specific to that effect, but I think any meat that is smoked or cured is probably not as healthy as one that is fresh.
I think that's a great
I
answer,
think
Mary.
that's true. I think that they say that many of our cancers that used to be so common, such as gastric and that, as our diets have changed and we eat less of that, I think some of those cancers have gone down. So I think there is an association with that.
I think there is too. I've heard that. Winter, 72-year-old male suffers from sinus trouble, hay fever year-round, often worse in the winter. What can he do? I think steroid nasal sprays is a wonderful
probably
thing,
good.
and it's now over the counter. I prescribe a ton of that stuff.
That's probably
I
a
do
good
too.
idea.
And I I have people that take it year round and have for years. But yeah, it sounds to me like the problem is the underlying, allergies are the underlying problem that predisposes to the sinus infection.
Here's another pancreatic cancer. One of caller's parents died from pancreatic cancer. Is caller at risk of this? Is it a genetic risk factor for pancreatic cancer?
There are certain gene conditions that do have increased risk of pancreatic cancer. I would say most of them probably are just, something that we don't really understand why pancreatic cancer is there.
But there certainly is some genetic things.
There are some genetic,
endocrine,
yes.
neoplasia things.
Yep.
Yes.
And it runs with what? Thyroid disease, parathyroid diseases, pituitary abnormalities. When you see those things, kidney stones.
But much pancreatic cancer would be a cancer that, it's like the 6th most common cancer, but does not have the genetic predisposition that colon, breast, or some of the other prostate cancer would. Those 3, I would think much more about family history than with pancreatic.
Great discussion, great answer. Brookings, what is the urinary sphincter paralysis? So the sphincter is a thing that closes off, and when they lose the sphincter for there's a lot of reasons, they have urinary incontinence, and there's not much to do for it.
It's
hard to fix.
It's a tough problem.
They can go in and try to surgically recreate one, which is done sometimes after men that have had prostate surgery that have this problem. But that's about the only situation I'm familiar with it occurring in.
Well, and if you have paralysis, I mean, if you lost the nerve to it,
you have to figure out why did they get the paralysis, and that's a tough problem.
Yeah, I think just catch it and live on. I mean, it's not the end of the world. Yeah, there's a lot worse things that you'd like to. Just put a pad on and go out and hang with friends and not worry about it. That's easy for me to say, but I do think that staying in the igloo and being afraid of that is a bad thing. Caller, blood pressure is quite variable, has been put on medication, and now his blood pressure is too low. Now, I get that a lot. You treat the high, and then it goes too low. And what do you any comments about that, you guys?
Well, I think it's not an uncommon thing. Certainly as we age, the pulse pressure can increase, and the pulse pressure is the difference between your top number and your bottom number. On most people, it's about a difference of 40. And as that number increases, and as we age, that is more likely a problem where that bottom number gets too low, especially, and then you become symptomatic.
Right. And their vessels get stiff, their heart stiff, and then when you lower that top number, down they go when they stand up. You're much better off letting the pressures go high.
I think they've adjusted some of the levels that are recommended because of that very problem. Because let's let some of our elderly people run a little higher rather than run them low and have them fall and break a hip or something.
Well,
it's not good.
The risk of the hypertension is milder dementia and strokes, and we know that it occurs, but we know that years and years and years to happen. It's not going to happen overnight. And falling and breaking a hip,
a big problem.
Slamming your head against the wall or floor, that's not good either, is it?
That happens quickly.
That happens pretty quickly. Yanked
pretty
90,
fatal.
Pretty fatal. 92, caller has been taught to wear yellow rubber gloves like those in the dishwashers to put support hose on and off. Our advisor, Mr. Erickson, doesn't use those, but I have advised rubber gloves to help put those hoses on because it gives you a better grasp. Have either one of you had experiences with that?
I have not.
It's made it easier for this experience. Whatever you need to do to get
whatever works.
Wear those hoses.
Wear them, whatever works.
Baby powder can help put on support hose. Hey, how about that?
Like it. Yeah.
Caller has rheumatoid arthritis without nodules and has a harder time finding shoes that are comfortable. Any suggestions?
Certainly, they can, for diabetics, we make diabetic specific shoes, and they can actually mold the shoe for you. And you might go to a place that sells diabetic shoes and just say, hey, can you mold the shoe for me? Because I'm having a hard time finding a shoe that fits me in the regular world.
I think finding diabetic shoes for rheumatoid arthritis is just exactly the right answer. So we've got just a half a minute left. Take-home messages. Mary?
I'm going to say it's a beautiful South Dakota winter, and it's good to get out and enjoy and be with your friends and just keep active. That's our theme.
There you go. Dan, I've just got word. We got 30 seconds.
Exercise, maintain your weight, and if you can lose a little weight, do that and get your immunizations. I think if you can do those three and eat sensibly, if you do those things, you're going to be healthier.
Common sense. Get your vaccinations, get your flu shot, and if you're sick, stay home. So
Stay home if you're
don't
sick.
spread it to everyone around you.
Great winter words of advice. We thank you so much for joining us tonight.
Thank you.
We'll
Hey,
be
thanks,
right back after this.
But what if Mary comes out of the coma?
I will forever be with you, even if she walked through that door right now.
How's it going? Yo.
You never know where you'll find the flu bug hanging around this time of year. Get vaccinated. It's free for children 18 and under. Because stopping the flu starts with you.
It's been known for eons that in this northern clime, some people feel the winter blues set in when the nights become long. But it was a physician from the National Institutes of Health in the 1980s who first named that darkening of mood in winter as seasonal affective disorder, or SAD, SAD. Paradoxically, with the holiday season, mood can significantly sadden in 5 to 20% of us, depending upon somewhat on how northern your exposure may be. Some people are just minimally affected, but those with a major depressive illness or manic depressive condition may be severely impaired by seasonal change. Certainly those who socialize poorly, move less, live in darker places, and hibernate indoors are at much higher risk for wintertime blues. The theory is that long nights alter melatonin and serotonin brain chemical levels, changing our biologic clocks. Some experts think SAD is a reflection of thousands of generations when food was scarce in winter, making it necessary to turn down and do less. It's not hard to believe that body juices and thus mood can be influenced by light. Just think how poinsettia leaves turn red or the Christmas cactus blossoms as our winter sets in. Maybe it's not wrong to settle in on your favorite couch in front of a warm fire, wrapped in a throw, engrossed in a good book with a hot cup of your favorite winter beverage. Maybe even snatch a nap. Perhaps we should allow ourselves to take a little time to recharge before the excitement and high energy of spring and summer. But we cannot forget how physical exercise every day keeps the doctor away. Winter without exertion means a springtime of weakness and injury. We must keep fit, even during the winter weather, and even if that means exercising indoors. I read one report that those living in Iceland do not struggle with SAD. It's thought their lifestyle of rigorous outdoor winter physical activity, exposure to winter sun, and diet of vitamin D saturated fish is the tonic that prevents sadness. For those who are possibly harmed by a bad mood brought on by the darker winter season, you might benefit from the Icelandic attitude of regular exercise daily, plenty of early morning light, outdoor sun when possible, and a diet that includes enough fish and vitamin D. And maybe it's okay to take some time this winter to cozy up and recharge a little too. Well, this brings us to the end of our show this evening. For more of this discussion and answers to the questions we didn't answer during the show, join us for After Hours by going to our website, oncalltv.org. I sincerely thank our fantastic guests tonight, Doctors Mary Milroy and Dan Meagard from Yankton. Thank you very much, both of you.
Thank you, Rick.
Writer John Steinbeck knew why we have seasons. What good is the warmth of summer without the cold of winter to give it sweetness? And until next time, stay healthy out there, people.
When you are in pain, any relief is welcome. If you suffer from chronic pain, it can be a burden on your life that may be unbearable. But how do you keep the regular use of pain medication from turning to abuse? Pain medication, use and abuse. Next time on Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you. And we had some great questions.
Good questions.
Here's from Minnesota, 84-year-old woman. What causes twitching muscles in the legs? That's a good one.
That's a good one. And there may not be a good answer, but there will be an answer.
But give it anyway.
You know, and I have had some of that myself, where I get a little muscle group that twitches, and sometimes it can be related to physical activity. If you're doing a different activity, sometimes we'll see that, you know, but I think in most cases we can do tests and we can look at your electrolytes and your labs and stuff, and to be honest, we don't find anything.
I've had people say, oh, it was the calcium. I took calcium tablets, they went away. I've advised that, made no difference.
Right.
It's the potassium. Oh, I've got low potassium. You check, it's not the problem. But I think that the biggest problem with leg spasms that I've seen, which is a little different than the twitching, the leg spasms that I've seen is when the edema goes in and out. Somebody who has edema in their legs, and the best answer is use those support hose and get the edema out with elevation and walking and maybe diuretics. But you need to get it out and then keep it out. Twitching, I think exercising induced, yeah. Del Rapid, 76-year-old woman, what causes neuropathy in the legs? That's another similar deal.
Well, most people are going to just assume it's related to diabetes, and diabetes is a very common cause, but to be honest, the most common cause is idiopathic, which means we don't know. It can be associated with a huge number of conditions, but it's a very frustrating problem for the patient and also for the physician, because you know, we can maybe give you some medicine to decrease the symptoms by 50%, but we can't cure it.
A little amitriptyline, a little
Neurontin.
gabapentin. Yeah. Mary, any addition
No,
to
I'm going
that?
to say it's kind of a tough one. You know, it's.
You know what I do? I give them all B12, because I don't think B12 levels are very safe. I mean, are always answered when B12 deficiency is there. I've had almost normal levels or normal levels, you know, low normal levels in people, gave them B12 and the numbness went away.
Okay.
I had one other person who had numbness all over their mouth and they were taking zinc, and we stopped the zinc and the numbness went away.
Oh, wow.
I've seen it with thyroid disease too, where they're hypothyroid, you replace the thyroid and the neuropathy goes away.
Right.
But not very many reversible causes.
Yeah. You got to check the thyroid, check the B12, take 1,000 of B12 and see if that helps.
Yeah.
Watertown, which patients need the injection to improve bone health? Does it really work? Prolia. Are you a big fan of any of these bone density meds?
I don't know if I would be qualified as a big fan. I think they have their place. You know, I think for people that have osteoporosis, you know, certainly the insurance company's not going to cover it unless you have osteoporosis. If you have osteopenia, which is just a decrease in the density of bone to some degree, insurance is going to cover it. And so, you know, but you'd have to have osteoporosis based on a bone density study in order for this drug to be covered. I've used this drug.
And other drugs too.
Yeah, I've used this. I've used this drug minimally. I think it has a place, but I've not used it a lot as of yet.
Yeah.
And you know, I'm going to say a lot of times I think it's good for people to know what their bone density is. And that, you know, we've been really kind of talking about exercise, but I can tell you, you know, if you do some bone loading exercise and you take some calcium and vitamin D, you know, maybe you don't ever need that stuff.
Yeah,
so keep on top of it. You know, when it is just maybe some mild change, it's bone loading, and it's that stress on your bones that strengthens them.
And it's for
with good calcium. And, you know, I think what's happening is, you know, so many people nowadays are, you know, drinking a lot of soda pop. and they're not having milk
Phosphates
and
are
water,
taken-
and it's leaching it out of the bones.
Yeah.
And so I think dietary and exercise goes a long way with that.
Yeah.
And it starts for women, you know, starting a couple years before menopause is where the bone density just takes a dive for the worse. So that's when women, because this is a bigger problem in women than men, that's when women really need to be aware of their bone health is, you know, within a couple years of menopause is take control.
Why would you take a pill when it's the exercise that makes the difference? I totally agree with you.
And
That-
drink your milk.
and-
Drink some
and-
milk and calcium and not so much soft drinks.
Yankton, 55-year-old caller, is uninsured and has lupus. He does research on the web trying to help himself and reduce costs. Any advice about lupus, either one of you?
Well, lupus is an autoimmune disease, you know, and it can affect everybody differently. It affects a lot of different organ systems in the body, and you know, it's very varied from one individual to the next. You know, there can be lupus that involves only the skin, but there can be lupus that involves internal organs. You know, specifically, it likes. You know, it likes joints, it likes some other internal organs. It can affect most anything: your brain, your kidney, your heart. Yeah, you know, so it's a tough disease, but you know, very similar to, let's say, cancer, in that there can be very mild cases of cancer, there can be very severe cases of cancer, and lupus has a huge spectrum. The treatment would be based on where you lie in that spectrum.
Right, and those I try to define as well as I can, and then I hand them to the rheumatologist because it's a cutting-edge, advancing thing.
It is, and a lot of different drugs they can treat with, but most of them are very expensive, which may not be an option for this caller.
That's right.
But you know, even that, I think it's good to, you know, don't just do it alone. Work together, partner with your family physician, your primary care provider, to make sure that you do have good ongoing kind of longitudinal care for that, because it is such a spectrum. They can help you look out for some of the danger signs. So don't do it alone.
Don't do it alone. And methotrexate, if that's usable in some cases, it's not that expensive.
It's a pretty cheap option, which has been around a long time.
Here's from Sioux Falls, related to early question about mixed martial arts. How do you feel about cage fighting? Is it okay for our community?
That's
a great question.
I've never seen a cage fight myself.
Yeah,
so I don't
personally,
know.
I wouldn't jump in a cage myself. I'd be concerned about the long-term health outcomes
Head trauma.
and the short-term health outcomes. You know, you think of and the head trauma. You know, and repeated head trauma. You get concerned about the Parkinsonian effects of that. Muhammad Ali, all the times he was hit in the head, he's kind of the poster child for head trauma. I'd be very careful.
I'm not a fan of it. How do you get rid of the cellulitis in the antibiotic? Oh, the cellulitis in the antibiotics and prednisone. Antibiotics and prednisone has been tried. How do you get rid of cellulitis? Lower leg in a diabetic. So cellulitis in the lower leg of a diabetic, tough area. I would say number one, support hose.
Support hose.
Elevate the leg, get the edema out.
Yeah, and you know, if there's truly an infection there, you're going to need antibiotics. And because you're diabetic and there's an infection under the skin, any bug that you can imagine is possible. For a non-diabetic, you're going to think of bugs that are on our skin, staph and strep. But for a diabetic, any bug that you can think of is a possibility. So it's a much more difficult problem in a diabetic than in a non-diabetic.
I would say the biggest issue is to get the edema out. And the way to do that is wrap with ACE wrap, support hose, elevate, diuretics, anything and everything to get the edema out, because if you get the infection set in, and the only way you're going to get that antibiotic in there is to get that edema out. But that's hard for people. Yeah. Here's the last question from Vermilion. How often should a woman get a mammogram after the age of 50?
Okay.
Mary.
All right. I'm going to say there's probably some controversy about how often to get mammograms. Most people do believe that every year is what most of the national organizations here. I know there's some places that go every 2 years. But I would say most of the national organizations in the United States are still standing by the yearly, although I will say that there are a number of national organizations that have task forces examining that right away. I mean, right now. So I think it's a moving target. I would say stay tuned. Right now, yearly is a good idea. But I know that both the American Cancer Society and the U.S. Preventive Service Task Force are forming, they have groups working on it right now, so kind of stay tuned. They're looking at the evidence right now.
I think the ACP came up with every other year if you've had negatives after a period of time.
Yeah.
How about after 70?
You know, I think that's a judgment call between you and probably your primary care provider. You know, I think if a person, we have people who are 70 and they are
50.
active and healthy and they are 50. I think you have to say, you know, what's your, you know, you can have a very elderly 60 and a real young 80. And so I think you have to say, what's risk and benefit? You know, we know that there's downsides to do mammograms. Maybe we have you get callbacks or biopsies. And if you are 90 in a nursing home, you know, we probably aren't going to help you. We're not going to help you. So that's a good time to stop. But if you are 70 and healthy and, you know, your average life expectancy could be 85 or 90, well, you've got 25 or 30 years on the line, and then it might make a huge difference.
Right. Final questions that you should answer. Here's a bunch of questions that you had thought about.
Yeah,
Have you thought about any final? I know we got a lot of talk about breast cancer. Dan, one final.
Yeah.
Let me refresh my memory. You know, I guess one last thought would be on fall avoidance in the wintertime. You know, and I think probably the most important thing is we've all had this beautiful ice storm here in the last few days that covered all of eastern South Dakota. And I went out, we had a bunch of kids that came to our house last night. I told my son, let's go out and chip the ice off the sidewalk or the driveway. And I think I about fell down 3 times, you know, trying to do that. So the main thing is wear appropriate shoes, something that's got a rubber base that you're not going to slip on. If you don't normally shovel, don't begin in a storm. Hire the neighbor kid because they're going to do it for $20 and they need the money anyway.
Right.
And if you use a cane, make sure you have your cane when you're out there and make sure you replace the tip on the cane. And then when you come in the house, take your shoes off right away because you might have snow or ice underneath them and you walk on a hardwood floor or on linoleum and you're gonna slide inside instead of out.
And dress warmly, avoid hypothermia, avoid frostbite. So dress appropriately. And you know, any of us who've had teenagers, sometimes we know that you have to kind of check them before they leave the house.
They're wearing T-shirts.
T-shirts.
Yes.
And you know,
year-round.
Carry a survival kit so you got some, you know, good warm boots. You know, what if you have some car trouble?
So what a joy to have you. Thank you again so much for doing this.
Thank you.
And thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at our regular time and call in or email your questions and then watch for Prairie Doc Perspective column in your local newspaper. Listen to your Prairie Doc Conversation radio show on a station near you and follow us on Facebook, Twitter, and Pinterest. And until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.